bright light. Okay. Hey guys, I'm gonna be doing this little video for y'all. Sorry, I'm a little sunburnt, and that's gonna be okay. I wore this. I didn't know if we needed it, so I just wore it anyway. My name's Josiah Scott. I'm in the Cersei LP and nursing program, and I'm gonna do colorectal cancer for you guys. So here we go. My computer's been kind of weird, so I'm gonna make this painless as possible. Okay. So, colorectal cancer. Okay. Oh, oops. Jeez. First slide is etiology and pathology. There's different ways that it can form. Malignant neoplasms invade the epithelial cells in the tissues in the colon and rectum. This is the second leading cause of cancer deaths. As it said, usually happens in people who are greater than 50. Sorry, I'm awful at doing this. The type of cancer can be hereditary. They arise from the adenomous polyps. It's a group of cells that are found in the lining of the colon. And I have a little picture for you guys that will kind of help later on. They can be hereditary. The most common type is this Lynch syndrome. It comes from having non-polyposis cancer syndrome. You can also have diverticulitis and ulcerative colitis that can also increase your risk of having colorectal cancer. There's some risk factors down there. You could probably read them about what to eat or how to eat to make you not be at risk for this. And of course, smoking, drinking, obesity, and diabetes are going to be most risk factors for most of the things that you have. Okay. Scroll down. Clinical manifestations. I didn't really find a whole lot on the book about this. Just it said signs and symptoms are based upon location. Have a little picture of different location sizes in here. Sorry, this is awful. I know. Usually doesn't appear until cancer is advanced, so it's almost silent until it gets on in the later stages. My bad, I'm sorry. And there's, it won't focus on, there, different stage types, and there's some locations of where it could be. It doesn't look very good. There you go. All right. So, assessments, you're going to look for changes in bowel habits, alternating constipation between constipation and diarrhea. So, if you have constipation, it's more likely going to be in the descending colon because, the feces holds there, and you might have some diarrhea. You can be impacted. You can have rectal bleeding because it can just be so packed in there, and it could potentially harm the lining. The ascending colon usually doesn't have any signs and symptoms. I guess. Sorry. Oh, awful. Collective data, nausea, vomiting, weight loss, abdominal distension, blood loss, and anemia, because if you're bleeding from your rectum and you're losing a lot of blood and you don't have that iron, if you're having diarrhea, you don't have those electrolytes or anything like that, so you could also potentially have some electrolyte imbalances. Here's a little picture. Let's see if I can, there you go. Just some signs and symptoms. Increases with the age of 50. There's some foods and stuff that would be recommended to eat. Let's see what else I can say. You can have weakness, Also, because if you're losing blood and you're losing all these electrolytes, then that can also be a problem. You can have excessive flatus and cramps also. So let me just scroll down. Alright. Diagnostic testing. So you can identify cell type with, I don't know what that almond is about. Oops, sorry. With testing, there's the fecal occult. This is the picture of a fecal occult test that you can do in those little strips that we talked about in class. That's like early screen testing, endorectal ultrasound. Baseline age for you to get a colonoscopy is 50. You can have a physical and rectal exam to see if you have this, and sometimes they use barium enemas to help. This is a picture of a CT. Well, A and B are the ultrasound, CD or CT. You need to have, with this, you need to have routine physical exams. You can also have a digital rectal exam because the rectal polyps that you can have, those little cells that build up in your rectum, you can actually feel those with the rectal exam with your fingers. But this should not be used for rectal occult testing, of course, because you wouldn't want to use your finger to do that. You can have a upper GI series. You can have an abdominal series, a barium enema. You need to monitor hematocrit and hemoglobin and electrolyte levels because they can also be, messed up with this type of cancer as well. I think that's all I have to say about that. Let me scroll down. Okay. Medical management. You can do chemotherapy. Of course, chemotherapy is when surgery and radiation doesn't work. If it's incurable by both of these things, if it metastasizes, suspicious, or I don't know what that red used tumor size is. I'm sorry. Reduce. That's what it means. Reduce tumor size and relieve signs and symptoms. If you have surgery, you only have surgery if you have an obstruction or health. Based on your health status, if you're declining, you would probably want surgery. Let's see. Chemotherapy is also for palliative care when you really just can't do much else for the patient or client. Then the surgical also depends on location and presence of the obstruction. You also do surgery if you're suspicious if it has metastasized as well. And I put these other 3 in here just to talk to you about it for a little bit. A right hemolectomy is it's a resection of the ascending colon and hepatic flexure. A left whatever. Okay, you know what I'm saying. Resection of the splenic flexure it's usually in the descending colon and the sigmoid colon, and upper rectum. And the anterior rectosigmoid resection is also in the sigmoid and descending colon. Those are just 3 little parts that are just little tidbits of information. Yeah, and usually chemotherapy, yet again, you're not just going to have one drug, you're going to have different kinds, to kind of attack and help as much as they can. Okay. I'm so sorry, guys. I'm really not good at this. I don't need to be a teacher. Anyway, nursing interventions and patient teaching. Pre-op there's usually a bowel prep. There's 3 to 4 days that you are on a liquid diet. You have laxatives with it and oral antibiotics. This is all to just sterilize basically your whole GI tract. You turn, cough, and deep breathe. You teach the patient how to splint the wound and do leg exercises. You talk about a stoma because you have the stoma place marked before surgery because they might end up having a temporary colostomy for a little bit. You teach them about a catheter, IV, NG tube, teach them about all that. After they do surgery, you're going to monitor them, their signs and symptoms, monitor for bowel sounds. That's the most important. You got to make sure they have bowel sounds. Check the drainage, you check the dressing. I don't know what that thing in the middle is. Nutrition, pain level, sorry you can't really see it, but nutrition, pain level, electrolyte imbalance, and stoma care. You empty and you cleanse the bag. Managing, you can have a sitz bath if you want to irrigate the site that they did it on. If a stoma is planned, the therapist should be notified so that the stoma site can also be marked before surgery. And it needs to be placed at the best site for the patient. And this little tidbit at the bottom, sexual dysfunction for both men and women related to with removal of the rectum. I just thought that was kind of interesting. But I don't know, I just put it in there because I thought it was interesting. That if they remove the whole rectum, you could have a sexual dysfunction. But, okay. Moving on. Oh, that's blank. That's the end. Okay. That's the end. Okay. But I guess that's it. Okay. I'm so sorry, guys, but there you go. And if you missed anything, y'all can email me and I will tell y'all more about it. There's that picture a little better. Well, there. A little better of the types. But if y'all have any questions, just email me. And again, I'm sorry for being so bad at this. Okay.